This is a 69 News special report.
Studio, I'm Rob Vaughn, and this is indeed a special report, a live conversation about the coronavirus outbreak in this country and even in our area, and preparedness for things happening in our area. We have two expert doctors who are with us tonight to take your questions. They'll take some of mine and some of yours through email, Facebook, and calls that can come in during this half hour. COVID-19 at WFMZ.com is the email address. We'll try to get to as many of these as we possibly can. And of course, there are serious concerns. There are serious questions out there, and everyone's feeling this. We're seeing sharp increases in the COVID-19 infection rate all over the place, and increase of some deaths. We have a death in Pennsylvania now. Governor Wolf, by the way, just to get a couple of quick news items out of the way, has just, toward the end of our newscast at 6, ordered that all non-life-sustaining businesses in Pennsylvania close now. It's an order from the governor. It's to happen at 8 o'clock tonight, and the state has put out a list of businesses with yes or no on the matter of whether those businesses may stay open in their physical locations. You can find a link to that at WFMZ.com. It's a 5-page list. Looks like this, and you can see where your business fits on that and whether you are, in fact, supposed to be closing. Also, I mentioned a death in Pennsylvania. More breaking news. A family that had a man who lived here in the Lehigh Valley and died yesterday had two other relatives also die. They live in central New Jersey, and now ABC News has just reported that a fourth member of that family has died. So all of that to get us started, and let me introduce my guests tonight. With us right here in the middle, and we're trying to keep a proper distancing here, of course, Dr. Timothy Friel from Lehigh Valley Health Network, Dr. Jahre from St. Luke's University Health Network. Thank you guys for being here once again tonight. We talked the other night. To great profit. We had lots of good comments about that. So we appreciate that. I want to start with what's happening. We have so many things to get to, but from coast to coast, there are concerns about supplies and so forth. Masks and the CDC guidance that if necessary in a real pinch, you could make a mask. And we're seeing that kind of thing happening. And just got an email from, maybe you guys know him, local MD, Thomas Brendecker, who says our office has a serious shortage of masks. We have no PPE, personal protective equipment. It sounds like they're kind of alarmed. I am a physician, cannot allow my staff to be exposed, and he suggests that people who bought masks personally decide to just don't keep them, but give them to the local doctor's offices. So where do we stand on the issue of supplies, Dr. Jahre?
Well, there's no question that there's a challenge when it comes to having the proper supplies. At the same token, we're a very innovative nation, and there are a number of different avenues that are being explored right now in order to make sure that we do get these supplies. So there are some alternatives. For instance, we now know that industrial masks can be used, and they are just as good as medical grade masks in many cases. We also know that 3D printing can furnish masks. These are just some avenues that are available to us. And then there are now governmental agencies that have stockpiles that are releasing some of those supplies. So I'm not trying to underestimate this, but I do want to say that there are a number of things that are happening right now that will hopefully help us meet this challenge.
Dr. Friel, what do you think?
I totally agree with Jeff. So it's a concern for all of us at the hospitals to make sure that we have enough personal protective equipment, masks, gowns, gloves, hand sanitizer, et cetera, for everyone. Our goal is we want to keep our patients safe who are seeking their care, our care with us, but we also want to keep all of our colleagues safe throughout this. So as we move into this and continue to move through this crisis time, I'm hoping that it's going to continue to spur innovation. Jeff and I talked about this before. We really, really do need to spur the innovative tendencies of folks who are in the public who want to contribute in certain ways. So we are going to be looking to others to figure out ways to keep us protected during this period of time, to mass produce things that we recognize, if we don't change, might run out or might be in short supply.
Can I probe a little more sharply? That's my job after all. So do you have enough right now at the hospitals in your two respective systems?
The answer to that is yes.
Okay. The doctor, and it's going to vary from place to place, I assume, depending on how much the virus has spread in certain communities, Washington State, for instance, New York City. But a doctor this afternoon who I heard an interview of, Dr. Megan Ranney from an ER in Providence and with Brown University, says about the CDC guidance that you need to make sure you reuse masks and so forth. And she said from days on end, and that the doctors in her ER are terrified. Is that something, how can you reassure us here in the Lehigh Valley?
So I certainly agree that people are worried. No doubt there are some who are terrified. But what you just brought out is exactly what we're doing. We know that we can reuse the same mask or the same respirator mask all day in many cases. We are looking at ways of sterilizing those masks that are safe. Ultraviolet light, as an example, is doing that. So I want to reassure people that although there certainly is a challenge, there are a number of things that hopefully we can do that are meeting this challenge and meeting it successfully. The second thing that I'd like to bring out is that not everyone needs a full set of gowns and masks and et cetera, to do everything. And so what we're trying to do is educate our population, and that's a physician population as well as a patient population, as to what is appropriate.
Okay, and you have what you need on hand, at least in our area. We have seen the one death, unfortunately, in the St. Luke's system, and that's connected to that family in New Jersey, which just a quick question about that. Some people are wondering if, because of family physiology or genetics, you're likely to see that in one family to be hit so hard. What could you say real quick about that, Dr. Friel?
So I don't think we know enough yet, and this is a virus and an illness that we're learning more and more about with every passing day. There are more people focused on understanding and learning about coronavirus than any other thing right now. It's certainly taking the attention and the focus of almost every American and every person living across the globe right now. We certainly know from certain families, in this case and perhaps others, that there are issues related to common exposure. We just don't know enough about genetics and predisposition in families that might increase risk. More of that will come, and you can bet that families like this and other circumstances are going to be analyzed and studied incredibly carefully so that we gain better insight into this illness, how it spreads, and how it impacts individuals in perhaps different ways.
Now, naturally, everybody's concerned about what's happening everywhere and wondering whether things that are really difficult and terrible in certain other places could happen here. And I've seen the big news organizations like the New York Times and the Post create these graphs and tools you can use and drag it along and even specify your area, so you could look at the Lehigh Valley theoretically and see how many beds are there. If things, I know we want to flatten the curve, but if things continue the way you feel like they're going here locally, will we see our beds run out?
First of all, we don't know. You have to understand that these are projections, and both of our institutions are running these projections as well, and we're running it for worst case scenarios. We're hoping for the best, but you have to plan for the worst. And the other thing that one has to realize, and very much it's sort of like warfare, that you're going to get a lot of things occur that are totally unexpected. Not every community is alike. There are major differences from one community to another, so I would be very careful about transposing someone's experience, for instance, in Seattle or California to the Lehigh Valley. But I can tell you that we have that constant plan going forward that's being adjusted every day based on further knowledge, and we are working together, because that's very important for our audience to know that there's no competition in this. No one is trying to take an advantage of this. What we're doing, we realize we have a responsibility to our public, and we are doing what we can to make certain that they're safe.
Yeah, good. We see testing questions. The other night we were talking about that very thing and concerns about some of the questions, and I have dozens, if not hundreds of them from viewers, are, hey, can we all get tested? How will that work? Or why in certain places aren't tests available? What's the, at least the initial reply to that?
So testing, getting better and better, but still not perfect. We recognize when the epidemic began and we had our first cases in the U.S., we probably weren't as prepared as we should have been. Tests weren't widely available. The availability of tests has increased significantly over the course of the last week. We've been aggressively testing within the local region. Our focus of these early tests, though, has really been patients who have symptoms, people who are admitted to our hospitals, or those who are in our community with symptoms related to possible coronavirus or the other many respiratory viruses that are currently circulating in the community. So as tests become more available, we expect that we will continue to refine our recommendations for who should get tested. But right now, we really are encouraging, in the presence of limited supply and the backlog of test processing, we really do want to reserve those for those who are symptomatic. The one other point I would add, and again, I think this is, Jeff and I and other infectious disease docs, we continue to talk about this. We're in the midst of an almost unprecedented influenza season. So this has been a very, very brisk, long, drawn-out influenza season that would be garnering a lot of media attention right now, were it not for a superimposed pandemic. And at our testing sites across the valley and beyond, we are continuing to diagnose people who have influenza A, influenza B, parainfluenza, RSV, rhinovirus, the thing that causes the common cold, as well as strep. So other things that commonly happen are still happening, and that's what makes us a little confusing. It makes it a little challenging, and it's certainly increasing to some of the anxiety that folks have, because these respiratory viruses are still circulating among families, in workplaces, et cetera.
Right, so some people have some symptoms now, perhaps. Some of those things we hear associated with coronavirus, or maybe just with the standard flu. If they're actually right now experiencing those things and they're thinking, what should I do? What's the answer?
Well, we have a screening process to try and ferret out those people who clearly do not have this disease. Example, we're in the middle also of an allergy season, or at the beginning of an allergy season. So people who have known pollen allergies and they have primarily a runny nose and itchy eyes, that is not a reason to get tested. What we're finding, and again, I want to underscore exactly what Tim is saying, is that we have people that are asking for tests in order to go to work. And I think there is a misconception about that. If you test people who absolutely have no symptoms, you're getting a result that is accurate for that period of time. It's not going to tell you what's going to happen the next day or the day after that. So it really doesn't suffice. The ramping up capability is enormous. I mean, as an example, we have the potential right now with the current platform to actually do over 1,000 tests a day. That also means, though, that we have to have the proper materials. And one of the things that's very short are the nasal swabs and the transport media, and we're working on that in order to make sure that we have adequate supplies for both hospitals so that we can run the tests that we can do to the maximum.
The situation now is, if you want to go to one of the testing centers that your two systems both provide, you have to see a doctor first. You can't just drive in, right?
So you can see, you can either see your doctor and they can make a recommendation. Many of our doctors who are equipped to do influenza tests in their office are also capable of doing COVID testing. It's really the same specimen that we use for that testing. But for folks who are at home, who are afraid to come out or uncertain, we are encouraging people to call their healthcare providers. They can call, and there's many different means. You can call your office and your doctor, and they can do an assessment of your symptoms and order the testing and have you show up at a test site. We have a video visit platform now where people are doing they're seeing a doc via video. And there's also electronic ways where we call e-visits, where we can communicate with our providers, and when appropriate, tests will be ordered. So we're doing our best to provide avenues for folks to get information and be directed for testing without necessarily the need to come in. Our goal, as much as possible, is to keep separate those who are healthy from those who might have coronavirus infection or other respiratory infections that are equally transmissible.
We have exactly the same platforms, e-visits, certainly the primary care doctors. All of our urgent care centers are able to accommodate this. And in addition, we have a hotline. You can call into that hotline, you can get screened, and if the screening process determines that you should have a test, that acts as an order so that you can then go and get that test done. And there are safe ways of doing it so that you can barely have to leave your car or stay in your car and someone can come out and do it, and you're not in a crowd situation. So there are multiple ways right now that someone can avail themselves of the opportunity.
Yeah. So many different kinds of questions to get to, but just on testing, one person asks, does it seem contradictory to say you just get a test, and we ought to just get tests if you have some symptoms that have started, and compare that with the news, and CNN was reporting this today, and I know you know this, that they're finding more and more that the virus is spread among people who are not yet symptomatic. How do you reconcile those things?
I think it's a play on words. When they're talking about not yet symptomatic, they're also primarily talking about people who have minimal symptoms. And I think that's the stress. So there's no question that seems to be a potential pool, and it's something that we are accommodating. As Tim mentioned, our criteria for having people have this test being done is expanding daily. And right now, I think people can be reassured that if they have any symptoms at all, or they have other reasons like close contact with a COVID patient, et cetera, that test would be ordered and will be done.
Well, can you tell me again the time frame from when you get exposed and infected, I guess is the right word, to when you start to show symptoms? And is it true, as we've been saying around here, hey, any one of us could be carrying right now because we have no symptom at all, but we don't know if we're infected?
So typically what we know about coronavirus is after exposure, the majority of patients will develop symptoms within 7 days. That is the majority. Most, I believe, are based on the literature, are developing symptoms by about day 5. Some by day 7, or the majority by day 7, and then there's a small group of laggards based on some of the early data that might develop symptoms in the 2nd week. But going back to what Jeff said, and I think we can't emphasize this enough, and I agree with Jeff, when they are saying that there are asymptomatic carriers. What I've seen and what my interpretation of this is, just like Jeff, that these are folks who have minimal symptomatology, but not necessarily no symptomatology. So it is true that not everyone with coronavirus or COVID who've been diagnosed have fevers. But most people do have something, and you know, whether it's early respiratory symptoms, a little bit of a mild cough, etc. That's why we can't emphasize enough, when people are sick or have any of these symptoms, we really do want them to stay at home. We don't want them coming to work. So no matter what you do, we implore you to stay away. That's the time to reach out, to get information and find out what you can do. We don't say that to be alarmist. We really do want to minimize unnecessary exposure when and if it's possible.
The only other thing that I would add is that when we talk about an incubation range, as Tim said, the average is about 5.4 days. But it is not before 2 days. And so that sometimes we see people who say, I just shook hands with someone that I'm worried about and I want to get tested the next day. It takes 48 hours at the very least, and very few people will develop symptoms at that point in time before you're going to have the disease and have a positive test.
So many questions that relate to those kinds of basic things. So for example, today I went through the Dunkin' Donuts drive-thru, got my coffee handed through the window, and immediately started thinking, how do I handle this? And do I find some kind of a wipe to go around the cup? Are those concerns warranted?
Well, what we try and reassure people is this. Although we know that the virus can live on inanimate surfaces, that doesn't mean that it's transmitted that way. And the lifespan of the virus on inanimate surfaces varies by condition. So you see figures of 2 days up to 72 hours. What I would say is, if you're concerned, make sure that you have some hand sanitizer with you. And as soon as you touch something else, you can wash your hands and with the sanitizer. And as long as you don't touch your face immediately afterwards, you're good to go, and you're not going to get the disease.
Dr. Friel?
Jeff has emphasized a really important point. It does, just because you come into contact with a surface that perhaps has coronavirus on, doesn't mean that you're going to get coronavirus. It really is, a transmissibility happens when virus comes in contact with one of your mucosal surfaces, typically in the respiratory tract. So your mouth, your nose, your eyes. Whether we like it or not, we all have this tendency that we want to touch our faces. I've been, and I'm guilty of it myself. Since this has started, though, I have this heightened heightened sense of I want my hands away from my face. So when you do this and when you are out and about touching, whether you're going grocery shopping or you're going to Dunkin' Donuts, as you suggested, before you start using your hands then to put things in your mouth or to eat or to do anything else, wash your hands. Soap and water, good 20 seconds, and really do it good and count.
If I'm in the car and I just got my coffee though, and I don't have soap and water, I don't have a bottle of Purell, grab some kind of a wipe, and failing that, I've got nothing but a dry napkin. Would I not drink the coffee? What do you think?
I would certainly drink the coffee. I wouldn't put your hand in your mouth, but I wouldn't do that under any circumstance. So I think by drinking the coffee, that's not a mode of recognized spread.
Right. People ask questions like, how dangerous is food delivery or the takeout?
So the same answer, I think, applies. If you're concerned about that, first of all, we have no evidence that the disease is actually spread that way. But for people who are particularly concerned, if you get a delivery and you unwrap it, make sure that you wash your hands. And I think the important point that Tim makes, because we know that Purell is in short supply, soap and water. It doesn't have to be antibacterial soap. Just wash your hands, and then before you eat your food, and you'll be fine.
Okay. We have a caller question here that I think may tie into this. Let's take a look. Should you be washing your produce and groceries purchased in a specific way to avoid contracting the virus?
So for produce, I would encourage people to wash their produce the same way that they should be washing their produce at any time.
All the time.
We have to follow the same rules that we've always followed, and there's other things and problems that you can get by not washing your produce. So we do really encourage folks to do that. Washing all the other things that you get from the grocery store, probably not necessary. Again, going back to what Jeff and I have suggested, after you're handling things, good hand washing. Purell, soap and water.
Yeah.
And you don't have to wash your produce with soap and water or bleach.
No, not at all. Just good old-fashioned rinsing.
Water on there.
Yes.
The 6-foot distance, we might be a little under 6
we're a
here,
little
Dr.
closer,
Friel.
yes.
That whole thing has been combined today with some comments like this one, that they've heard that that the virus can linger in the air for 2 minutes or so. So suppose I've kept my distance from you, but as soon as you move and I walk in that space, I'm susceptible. Any truth?
The spread, as we know it, is by droplet and not by aerosolization. And there's a big difference there. If you look at diseases like measles or chickenpox, they're far, far more contagious. So droplets tend to not hang out in the air for very long, and they drop off rapidly. And that's the current knowledge base. Good point. I think a lot of people are just concerned about whether they walk through certain spaces that they're in trouble. Should not be the case. The droplets fall to the ground. A lot of people have questions about their health situations. I'm a liver transplant patient with metastasized active lung cancer and so forth. My husband's employment partner is very likely infected with the virus. We don't know how they know that. He is currently being tested, and my husband's been in close contact with him for weeks. What do we need to do if he tests positive? So there's a lot packed into that question, part of which is just as someone who has health problems.
So I think a lot of it hinges upon the result of the person who's been tested. So if the testing for COVID-19 comes back as negative, or if another pathogen, nothing else to do out of the ordinary. I would encourage the person, this person with metastatic cancer and lung disease is at heightened risk. So doing everything that they can for social avoidance, all of that other stuff is important. If it is determined that the husband was in close contact with a person who is then diagnosed with COVID, the husband then would need to quarantine. And that's kind of the typical recommendations that we would make in these circumstances.
And in that example, the wife would be tested as well.
Yeah.
Okay, I read between the lines of some of these questions. I wonder if some of the older people who are sending in questions, who have some health conditions perhaps, because after all, many of in that age group do, or who don't, are just concerned about whether they ought to leave the house at all.
All right, so the CDC has published very, very good guidelines that someone can refer to, and I know that it's available on both of our websites. And what that includes is what they call a family plan for this. And if you have means at that point to make sure that you can be separated, and what we're talking about there is not close contact or touching type contact. If there is 2 different bathrooms, preferably use that. To be more diligent on how you wash surfaces. Those are the kind of things that you're going to want to do. If you actually have someone in the house who has the disease, then a mask would be appropriate for that person if they're in the same vicinity as anybody else. If you do those things, it's been shown in China, actually, that the likelihood of spreading it even to a household contact is actually quite low.
Is that right?
Yes.
Okay. So someone who's watching is 76 and is fairly healthy. They don't need to worry about going out and going through the drive-through necessarily, right?
So, no.
Or send the young person. I don't know.
Let's step back a little bit. The first question was, can they go out of the house?
Yep.
Yes, so you can sit on your back porch, you can go and walk through your yard, etc. It's a trying time for folks, and you can go stir crazy pretty darn quickly. So I want folks to be reasonable. There is no immediate threat to just going out and breathing fresh air. I think actually there's a lot of great medicinal and psychologic benefits to going out and breathing fresh air. You can do that within your own yard, on your own porch, and we encourage people. I think a little sunshine will be good for all of us.
As the weather is getting better, important. Absolutely.
What we are discouraging, though, is having a picnic in your backyard, with a large number of people. So what we do outside, for now, does need to change. But by no means are we saying that people should not go out. In a multi-generational household like this, though, a 79-year-old versus kind of their children and their grandchildren, I probably wouldn't be sending the 79-year-old out to do the family grocery shopping. You want to do all our best to minimize unnecessary exposure when possible.
Yeah. I think there's a very important point also to add to that, and that is what we're seeing is that there are a number of millennials who feel that the likelihood of this disease being severe in them means that they don't have to take any precautions at all. And there are a number of reasons why that is an erroneous thought. The first thing is that we now know that there are increasing reports of younger people actually coming down with this disease, although certainly not as high as the traditional risk groups that we've recommended. And the second that Tim alludes to is that you have a responsibility to the people that you live with who may not be as young as you or as healthy as you, and you can bring that back home. So, I mean, particularly now we have a lot of college students that are home, and they're looking at this as an opportunity to congregate with their friends and then come back in, and we would certainly discourage that.
Yeah.
So I'm the dad of 3 millennials, and
I was going to ask you about your own
kids. It is a challenge, and I think we've tried to have those important conversations about what this means and social responsibility. And I think it's something that we need to continue to talk to our families and children about. As Jeff agreed, there is that responsibility to make sure that they are not putting themselves in danger, but certainly introducing an element of danger to others in the family. Jeff brought up a point, though, and I think, to me, this is telling. The data that was presented for I think the first 2,500 patients in the United States, and if you look at those between the ages of 20 and 55, 40% of them they represented 40% of the people who've been hospitalized in this country. So those notions that were really, really common as we were preparing for this, that this is just an older person's disease, are not really true. And we really need to take heed to that as we think about this. And it's, I think, an important point that we need to emphasize to folks at all ages.
We're learning along the way.
Yes, and that's the point, that we keep emphasizing this is a novel coronavirus. It was not in society before December. It's barely 3 months old. And in this country, it's less than that for all practical purposes. And so we are learning quite a bit as we go. And the other thing is that not all societies are alike. If you compare us to the society in China, where there's a higher incidence of males who smoke, there are more densely populated cities, et cetera, there's a very, very different environment than what we have over here, particularly across the country.
Well, on that subject, one person writes in today, since China has now reported no new cases, what happened there that it's no longer a threat? Since there is no medication to stop it, how did it become less aggressive and new cases disappear? And what have we learned from that? Can we expect that to also happen here?
You bet. So China. I think, again, China, for us, we're going to continue to learn from China. China is where this epidemic began. So we learned a lot in the early stages of the epidemic. I think for many countries, we learned what not to do in the beginning. And then also, some of the interventions that were put in place in China that were eventually effective, social isolation. And this is a situation where the government really cracked down. They stopped transportation. They mandated people staying in their apartments. They cut down on social appearances. They really reduced the ability for folks to go to work, leave their homes, etc. It was that aggressive containment plan. It wasn't, you weren't able to contain, but they had an aggressive mitigation plan to really stop the spread of this virus. So that has led to their success. I think made a lot of news yesterday that there were no new cases. I'm cautiously optimistic when I hear that, but I think the story's not over in China, and China is not back to normal yet. China is not back to the way they used to go about everyday life. And as they cut back or reduce some of their aggressive social isolation policies and start to ramp up some business and other things, I think all of us are watching carefully as to what will happen and what will transpire, because we still recognize that there's a significant portion, a major part of their population that still remains susceptible to coronavirus, and the concern is that the virus will rear its head once again.
I would also mention that we've learned a lot from Italy, and when I've talked to some Italian colleagues and heard some interviews with others, what they are very ready to admit is that in the beginning, they did not take this seriously. There was this feeling that, oh, it's just the flu, it's really nothing to worry about. And so nothing was put in place until it was pretty obvious that it exploded. So all of the things that we're seeing right now, people would say, my gosh, isn't this a bit much? The answer is, no, it isn't. I think it's been quoted that you can't overdo this at this point in time. We're not going to do what the Chinese did. We're not that kind of a draconian society, but yet many of the measures that we put in place, and there will be others. I mean, if you've read in New York, they're thinking about what's called a shelter in place, where they won't let people out. These are all necessary right now to make sure that this is not a prolonged situation.
Now, we have a question from a caller who is saying, how long can we expect this to last in the USA? So that sort of fits in here. Again, one of the great unknowns, I'm sure, but you want to take a stab at it?
Yeah, it's unknown, and I wish Jeff and I had the crystal ball and we could predict. We certainly would love to be able to give folks a date. We just don't know. You mentioned a little bit earlier this whole notion of flattening the curve, and we've talked about it, but I think it bears repeating. For a virus like this, where there is no immunity and everyone in the community is susceptible, there's the risk that new cases will continue to grow and at a huge exponential rate until finally a significant portion, 70, 80% of the population is infected, and then you're ultimately protected by what we call herd immunity. The problem we have with coronavirus, because of the sequelae that some, and a significant number, can have significant serious illness that can quickly overwhelm a healthcare system that only has a limited capacity. So by reducing the spread of this and reducing the rapidity by which it is spreading throughout our communities, we are really hoping to prevent that from happening. We never will want to get to the point where the manifestations of this illness overwhelm our capacities in our hospitals to do that. What that means, though, is that we potentially could be prolonging the course of how this all plays out. What we're hopeful for in the interim, and that's if nothing else happens and changes. You have to remember that there are many, many folks right now, scientists, researchers, pharmaceutical, the government, et cetera, who are aggressively pursuing interventions that hopefully can change the course of this. So vaccination strategies, looking for new treatments, and those are the things that we're also hoping for that will also make a difference.
Many things we didn't even get to yet, but we'll take a really short break so people can take a breath, get a sip of water, us included, and we'll be right back.
This is a 69 News special report. This is a 69 News special report.
Welcome back. Thank you so much for all your questions by email, by Facebook, by phone. We appreciate that. We're still taking calls. We'll be showing you the number and giving you all that information to contact us. We can't get everybody's question in, but we're doing the best we can. As I sit here with Dr. Timothy Friel from Lehigh Valley Health Network and Dr. Jeffrey Jahre from St. Luke's University Health Network. So thankful for you guys coming in and doing this, a real service to the community. I want to do a little reset. As we started the program, we were talking about supplies, and people are alarmed, and people may have seen the interviews with the ER doctors who are concerned about what they have. And here in the Lehigh Valley, we had some doctors reposting on social media some things about the dearth of stuff that they need to do their jobs, and with the little headline, happening here in the Lehigh Valley too. Just give us a sense again about is that a concern? Are there people who are likely to go into one of your health network ERs with symptoms and wish they'd see a guy with a mask on, but alas, there are no masks?
Well, they will see a mask placed on the physician or whoever is taking care of them, and they'll also see eye protection. That we are doing. It can be various types of eye protection. We know that it doesn't have to be the official shield, that any kind of goggle will do. So the short answer is, as of right now, we're meeting that challenge, but we are certainly aware that this could become more problematic in the future, and we're doing everything that we can to use the equipment that we have appropriately, as I mentioned earlier, and we also are going through a whole reuse situation that's going to help us, I think, quite a bit.
I guess what I would add to this is that, as Jeff emphasized, we are encouraging our colleagues to use PPE appropriately. And it is a time of fear and uncertainty, even among the health professionals. And Jeff and I recognize this. This is our colleagues. We talk to folks about this each and every day. People without symptoms who are healthy are coming in for certain things that are perhaps routine will not necessarily see their physicians, nurses, and staff gowned, gloved, and masked, because at this point it is not recommended to do so for those who are not symptomatic and healthy. And part of that, we have some of our colleagues would love to spend the entire day with personal protective equipment, and we understand where that thought is coming from. But that's where we get into the realities that we do have a limited supply, not a shortage at this point, not a shortage like they're reporting in Italy where they've run out. But what Jeff and I and others are trying to do is prevent ourselves from ever finding ourselves in that situation. So at this point, we really do need to be thoughtful and reasonable and use our best judgment about when is the appropriate time to use the masks, goggles, gloves, etc.
As an example, someone who is intubating an airway, putting a breathing tube in an airway, that is a very high-risk procedure, and those people are covered to the max. That's a lot different than many other procedures that people are doing.
Sure. We have a caller question that pertains here. Let's take a look at that. I have an elderly father with caregivers. Should the caregiver still come, or is that too risky?
There are individual choices, and it's very difficult to make absolute statements about anyone's specific circumstance. So what we always say is that with anything that one does, whether it's taking a medication or going through certain other endeavors, you always have to weigh the benefits versus the risks. And so if that father or parent is not going to do well without that caregiver, then you try and make sure that you're creating a safe zone as much as possible. The caregivers should certainly be told that if there's any kind of a temperature or he or she is not feeling well, that's not a time to visit the father. And does it really require hand contact? I mean, well, I can't really talk about that individual circumstance. And then again, to make sure that that person washes their hands and uses the appropriate methods that we've talked about in order to protect their patient.
Is it true that people with blood type A are more vulnerable?
Don't know. No. At this point, there's no data to support that. There are many questions like this, and you can bet that there are a lot of people really looking in and delving into the data, but right now we have not seen conclusive evidence that that is indeed true.
There are many reports that come out based on what we would call maybe a single observation or two. That is not a valid scientific way of looking at these things. So when we talk about whether you should or shouldn't use non-steroidal drugs, for example, or are there certain blood pressure medications that may increase the risk, what happens is somebody will publish something on the basis of an observation with 1 or 2 patients, and all of a sudden it becomes the rule. And we know that when it's looked at rigidly scientifically, that many of those things fall apart. So I would caution people to make absolute judgments on those bases. It needs to have repetitive studies that are valid in order to do that.
Jeff is right on the ball with this, and in scientific investigation we have this notion of confounding factors. So a good example getting a lot of press is this whole notion of ACE inhibitors, a type of blood pressure medicine, and there's been some concern from clinical trials that perhaps folks on ACE inhibitors have worse outcomes with the disease. But we know when you really look at those who are taking ACE inhibitors, they tend to have underlying medical problems. They have heart disease, renal disease, diabetes, much more commonly. So we just don't know for sure whether that is a confounding association or there's anything to it. We know a little bit about the virus and where its receptors are within the lungs, et cetera. So there's some theories, but right now we don't have conclusive proof. As that comes out, you can bet we will continue to change our recommendations based upon good scientific evidence and fact.
And the International Society of Hypertension has already said that that is not valid at this point in time.
Okay. Someone asked, in fact, a few people have asked this kind of question about the difference between, or the wisdom of using ibuprofen versus acetaminophen. NSAIDs, I'm not sure what that is.
Non-steroidal anti-inflammatory drugs.
Ibuprofen, Motrin, and so on. Right.
So again, this is based on a few reports, and then the World Health Organization picked it up and made a broad statement. What most experts in this country feel is that that's far too early to make that statement. Certainly, I mean, if one can use acetaminophen, which is Tylenol, and use it safely, because there are people who shouldn't take that. So I would certainly encourage people to talk to their physician. And if they use that as something to drop their temperature rather than ibuprofen, no harm done in that situation.
Fully agree.
Some people asking about whether it's wise, and that's not so much up to you, but wise as to what their job continues. In one case, an older person who has lupus and working at a beer distributor. And of course, some of this is moot now with Governor Wolf closing off non-life-sustaining businesses, but still some who go and have regular contact, maybe they're the produce guy at the supermarket. They're wondering, should their businesses be closing down to people because they're having lots of contact with all kinds of people all day long?
It's a tricky question. And again, I don't think we have definitive answers. I know the question that was shown was one about landscapers spending time outdoors. And again, going back to one of the things that we talked about earlier, there's no harm to going out and doing work in your garden, mowing your lawn. We just don't want you to do it with large groups of people. So there's no inherent risk to just being outside with all of this. So I think that's important. For those who do have underlying medical problems or other conditions, then I think it becomes a thoughtful discussion that one should have with their physician about what they should and shouldn't do, and where there are alternatives for other people to do things for them, like do shopping, et cetera, at this time, then those are all important considerations.
And again, it's always a benefit versus risk equation. And what many people are doing right now is, by reducing that risk, if they can work from home, then they're encouraged to work from home in many circumstances, provided that they can do the same kind of job. And many employers are also thinking of ways that they can actually distance people. So we were talking earlier about self-checkout in a supermarket line that is more encouraged right now than direct checkout. There are a lot of different things that can be done to help reduce that risk curve.
This goes back to this whole notion of, I think we're going to continue to find great innovations in how we operate. It will no longer be business as usual, and I've said that over and over, but it certainly applies to healthcare, I think, as Jeff would agree, but I think all those in different industries, business will not be as usual, and it will force us to think about things differently, do things differently, and make different decisions for at least the near future.
I don't know if you saw the story in the MIT Technology Review. I don't subscribe, it's not what I usually, but it's referring back to this study done in London that even our federal authorities have been referring to, the one that had the worst case scenario referring to 2 million Americans dying. But one of the other aspects of that report out of the college in London was that we may see waves of this again and again. It may die down pretty well, the curve goes down, but then we need to be ready that there is no normal again. It may flare up again.
Well, that's a very important statement because, again, nobody knows. There are a number of reasons to suggest that, unlike SARS, which came and went, that this may have a low level in the community that could arise again. The one thing that I would be very certain about is if it's not this, it'll be something else, and that's why every place that has any kind of a healthcare responsibility has always been preparing for a pandemic. We always thought that it's likely to be another strain of influenza, and this came through. But this will not be our last. That is the one thing that I think everybody is sure of.
You probably have no desire at all to speak to political issues, but there's a lot of discussion about whether the federal government was way behind on this, and in fact, even into the past administrations where they did schemes and models on how these kinds of things could affect us, and were they ready? I don't know if you'd like to comment on that.
I think the one thing that one has to avoid, and we've been saying this over and over again, when you're dealing with public health, irrespective of whether it's politicians or the federal government, you're always going to get accused of either doing too little or too much. And we all know that looking backwards is a lot more accurate than looking forward. So I think that it is best at this point in time, yes, can we learn lessons? We learn lessons every day. We learn it in our personal life. And that's certainly true in the way we approach this pandemic, and there already have been lessons learned. Have there been mistakes made? Yes, I'm sure there have been, and there will be others. But the important thing is that we need to be able to be positive and go on and not play this blame game, which can paralyze us.
Yeah. Several practical questions from people. Is it possible to pick up the virus from sidewalks and walking paths when I walk the dog?
So
probably not.
Probably not a major way that this would be transmitted. And again, it goes back to your hands. Walking around with things on your shoes, your sneakers, etc. Very, very unlikely that that's going to be the issue. We're more concerned about contact with surfaces with hand and immediately placing those hands on your eyes, your nose, or your mouth.
But it does bring up another point, and I certainly agree. It's not likely to be transmitted through your feet. But if you have a household member that is suspicious for this disease or actually has it, that member should be separated from the pet. And the reason for that is that people will constantly be petting that pet, and the pet can act as a vector by actually having the secretions on the fur, for instance.
How about
so
receiving?
that needs to be taken into account.
Mail, newspapers, packages, things coming into the house?
Yeah, well, again, as we've said before, that has not been an active way of transmittal, but if you wanted to be safe, then by all means make sure that you will wash your hands with soap and water before you end up touching your face.
We've touched on some of these things. Is COVID-19 more contagious than the flu? There's been a lot of debate about that. And what are the differences between COVID-19 and the flu?
Sure.
So there's similarities between influenza and coronavirus, and there's certainly differences. Both are very, very transmissible. Coronavirus, the estimates are that for every infected person, there's the potential for them to infect another 3. So comparing to different influenza outbreaks in the past, some have been less transmissible, some have been more transmissible. Very similar symptoms, so fever, cough, body aches, all common with both. Coronavirus tends to cause more lower lung disease or lower respiratory disease. Both of them can be fatal, though. So we are still taking care of people who are really sick with influenza. It can cause very significant lung disease. It can cause pneumonia of and in itself, and it can make a host more susceptible to bacterial forms of pneumonia afterwards. The look of coronavirus in the lungs, when you look at radiographic appearances, there are some unique characteristics that are not necessarily telltale, but certainly there have been some consistencies that have been seen, so there's some radiographic differences between the two that could be significant, but they're both important infections. Why coronavirus, I think, is most different and why this matters now is the simple fact that none of us have any immunity to the novel coronaviruses. There were 4 other coronaviruses that we've known about, talked about for years. They Those more common are not the novel ones, but the more common coronaviruses were causes of the common cold. They could cause bronchitis, sinus infections, etc. But these newer ones, none of us have immunity to, and that's what is so telling. And we don't. Unlike flu, we don't have a vaccine.
Well, there are a couple of other things. In terms of death rates, it's been pretty established that for most influenza outbreaks, the death rate is 0.1%. The death rate over here, when it was originally an outbreak in China, seemed to be above 3%. But as more and more people with minimal symptoms were tested, that has gone down. So currently, and this is certainly subject to change as we get more of a database, it's felt that it's likely to go down to about 1%, which still makes it a lot more fatal or potentially fatal than influenza, but that remains to be seen right now.
Questions real quick on blood again. Could the virus be transmitted by an infected blood infusion? And if you donate blood, would the blood be tested for the virus before it goes into the supply?
The important thing to know that as of right now, there's no evidence that this can be transmitted through a blood transfusion. When you get transfused blood, it is not currently tested for COVID-19, but there is a screening of questions to make sure that a person who's giving that blood is not having symptoms that would prevent them from giving blood in general. So that's the current state of the art, and until that changes, that's what we're adhering to.
Yep. We talked about blood donation. We talked about people who have various healths. We mentioned a woman with lupus. One writes in and says she has MS. I'm wondering what precautions my husband and I should be taking. He still works at a factory. If I go to the grocery store, should I wear a face mask? We touched on some of these things, but what would you say to that person?
So I think using the same type of precautions that we've suggested for other folks. Those who have any chronic underlying medical condition, whether it's chronic lung disease, heart disease, diabetes, cancer, immunologic problems, etc., as much social distancing as possible, I think is clearly recommended. When shopping, it's using common sense. It's maintaining social distancing within stores. It's abiding by those really strong directives for hand washing after you touch things, when you get back, all of those things. The decision to wear a mask right now is, I think, a personal one. It has not been recommended broadly that folks wear a mask every time they go out in public. So at this point, there's no strong recommendation to do that. If someone was going to find themselves in a situation where they were, for whatever reason, they needed to have prolonged contact in a more confined space with a larger number of people, then the possibility of wearing a mask should be one that could be considered.
Amanda writes in, my mother-in-law is sick for 2 to 3 weeks with cold symptoms. She said she went to the doctor when it first started out. She was told it was a cold. Since she is still sick, should she be tested? Is that testing available?
Well, again, I want to emphasize that the criteria for testing has changed, and it would rely on some other circumstances, what kind of contact she's had. But we can say certain things in general, that for most people, particularly I'm assuming that her mother-in-law is older, that this disease advances. Sometimes it has very few symptoms to begin with and then has a sudden downturn. If she's been sick for 3 weeks with the same symptoms, I would say that that's much less likely. But if she's really concerned, there are a couple of things that can be done. First of all, there are common tests that can be done for many of the viruses that cause the common cold, and that can help rule out those things. And secondly, if she's really still very fixated on this, then now that we have more of an availability of testing, I think that she could qualify potentially to have the test done.
And people just need to do, as we said off the top, be going through their regular doctor's practices and get some guidance right there.
This is a time where we really do encourage people to be in touch with their physicians and their healthcare providers. It is incredibly important. It's a time where we're feeling more and more isolated and separated, but there are other ways to reach out. So simply picking up a phone and reaching out, this is a time where we need to have that great partnership between our patients and care providers.
Because you can get a complete history that way, and the right questions can be asked rather than trying to give a very quick answer to someone where you have some bare bones facts.
More questions for you, including this one from a viewer who had called in. Do you feel the U.S. hospital and healthcare system being privately operated rather than a centralized government system, kind of thing you find in Italy and England and so forth, is better positioned to treat this?
Well, there actually have been studies on that. And one of the things that by having a private system in the way that we have it is that you have hospitals that have tremendous amounts of equipment that actually is duplicated from one hospital to the other. So what's not really realized, in this country, there are a lot more ICU beds per population, or intensive care unit beds per population, than exist in almost any country in the world. And it's this kind of epidemic where that will come in handy.
Yeah, and I thought I read otherwise, but then again, you have to sift through the information that's on the internet, right?
Yes, you do.
We were behind the curve.
And it makes it sound like we're at a disadvantage, and the answer to that is no, we're not.
Yeah, I agree with Jeff. I think, again, if you look to the number of ventilators that we have, the number of resources, this is one time that perhaps some of those excesses will benefit us.
Okay. Is it recommended to cancel any non-urgent doctor appointments right now to prevent the use of any medical equipment that may be needed later?
Well, there's a difference when we talk about appointments and when we talk about elective surgery. So in terms of, we have made safe spaces and ways that people can feel secure by going to visit their physician. And again, we encourage any visit to a physician to have a conversation before at the time the appointment is made and find out exactly what the symptoms are. And so if it sounds like it could be anything that is even remotely related to this disease, there will be certain precautions that would be taken. So the bottom line answer is no, by all means. We're now certainly utilizing extra precautions, but you can have safe routine visits, and in many cases you should. That's a lot different than what we call elective surgery. That there have been a number of different plans around the country, and certainly advice to do so. Both of our hospitals have worked together to have a joint plan on what kinds of surgery should be done versus what kinds of surgery can be postponed. And again, that is a conversation that you should have with your physician, because it depends on your circumstance and what the potential danger is to you by not having the procedure.
Real brief, we're actually going to wrap it up at 8 o'clock, I've told.
Okay.
So,
yeah, no, I agree. And for the standpoint of surgery, it's not even so much a safety issue. There's also the element of conserving some of the materials that are used, the protective equipment, because when folks do surgery, there's masks, they're gloved in gowns. So we're doing our best to save that. And remember that not all visits require face-to-face. So I think we are moving into this world where business is not as usual, and we will be able to provide care to our patients in different ways. So some of those annual check-ins with your physician, et cetera, now we're going to start seeing more of them done via video, via telephone when necessary, but we will never be able to completely replace the need for face-to-face.
Okay, and maybe the last question we get in here relates to some other things about what the droplets that are on things. When we're done tonight, we're all wearing suits, we'll go home and we'll hang them up. Or should they be put somewhere else so the droplets on them, should there be any, can dry? What about clothing and whether the stuff...
Well, there's a very big difference between exposure to protective equipment when you're seeing sick patients and wearing ordinary clothing. So the bottom line answer is, again, wash your hands frequently. You don't have to dispose of your suit if you wear it. These are not disposable. And you just take proper precautions and you'll be fine.
But I don't need to wait 2 or 3 days before I use the same clothing again, right? There's nothing like that.
At this point, I would not recommend.
We would both agree.
All right. Well, listen, thank you, gentlemen, very much for being with us again and taking this hour. We are sorry we couldn't get to all the comments. We have tons of information at WFMZ.com on our coronavirus page. This program we've just done will be available on our website a little later if you'd like to see it again or refer to somebody else about it. And these guys' respective health institutions, which are the big ones in the Lehigh Valley Health Network and St. Luke's University Health Network, their websites have loads of information as well. So you want to check into that and tap into all those resources. Sorry, that's it for now. I'll be back with news at 10. Good night.
This is a 69 News special report.